Thank you, Dr. Namrata. Thank you, AIOS, for this wonderful OOPS webinar. I'm talking about perforation, intra-perforation in DALK. We know the DALK techniques have evolved, and there are so many things which came in DALK, but the revolutionary treatment of making DALK easy was Big Bubble by Mama Danwar. And we will stick to Big Bubble technique, and we will talk about different steps at which one can have perforation. There are many surgical steps which potentially can have perforation, from trephination, insertion of needle, big bubble, stromal debulking, opening of bubble, stromal excision, and finally the suturing. We'll go one by one. But before we start the surgery, we know the surgery starts from the draping to removal of the draping when it ends. Well, I start with first case where my over-enthusiastic assistant ended up perforating a descemetocele, which was posted for a therapeutic DALK. I had to use a manual dissection using trephine. I marked periphery, just marked it, and did a manual dissection, and finally put a C3F gas. Now, such kind of cases are true OOPS movement, because you know that you have planned entire surgery based on that descemetocele, and you want to preserve the cornea, and you don't want to give it up. And finally, on table, if you realize that you can't do it just because of one small silly mistake, is certainly embarrassing. We start dissection from the periphery, come towards the perforation area at the last, and make sure we do not disturb that area as much possible. Try to deepen the cornea in the periphery, try to make a pocket here so that you can tuck in the tissue. From the donor tissue, you can reduce the peripheral thickness so that it does not stand up too much, because you're not dissected the entire cornea there. And then once you take the suture, preferably take the size of the donor almost similar to the recipient size. And after putting the tissue, I'm separating the anterior attachment, and then put a C3F gas, which was kept inside. Post-operatively, patient had persistent edema and focal edema in that region, and had irregularity in epithelium. I had to do a temporary tausorrhaphy, but finally everything went on well, and patient improved vision with 6/9 with RGP lens, and the graph also remained clear. Coming to the proper intra part, first thing is the trephination part. Let's start with the trephination. Now, trephination, sometime when we do a very thin cornea, and when you're trying to manually deepen a little bit before making inserting the needle, you can end up perforating. Such kind of small perforation can be easily sutured, and you can again start the manual dissection from the opposite side. It can also happen with uncalibrated vacuum trephine, which happened in my hand. One such case I'm showing here, that an uncalibrated vacuum trephine which I used, and I had not used this trephine earlier as many times. I used to use Katina trephine, and this is Corneal trephine. And I ended up with 4 quarters only. I just ended up perforation. And mind you, I had to make sure that the blade was retracted properly and everything, but somehow this trephine didn't work in my hand. More than 200 degree of opening, well, the only possible thing was do a PKP. Then I thought that if I could suture the area which was open up, then the area which was closed, that 160 degree area, I started dissecting manually from there, and made the cornea as much thin as possible. The donor tissue, when I took, I made sure that donor tissue was secured without removing the sutures which I had kept in the superior part, and I kept the recipient tissue still in place. Finally, final 3 sutures, I removed the recipient tissue. The 12 o'clock bite I took along with the recipient tissue, which would have been there, and then I put air bubble inside full chamber, which I reduced after a couple of hours. I was not sure whether it will hold on or not. Post-operatively, yes, it held on. The graph cleared up, and patient was visually rehabilitated very nicely. The next step is needle insertion. That's the time where you can have perforation. Now, interestingly, these perforations are very small and the DM usually does not retract there, and it can be avoided by using cannula. Which Dr. Fogla has designed, and many other designs are available. If we find out there is a perforation there during the insertion, you can do manual DALK, pre-desmetic DALK, and there can be need for putting the air or gas post-operatively. Dr. Fogla has also designed a pointed dissector, which works very well along with the cannula. And there are many cannula, whatever works in your hand, it surely can be used. The next step is big bubble. Now, while making big bubble, if there is previous hydrop, so if there was very thinned out cone or sometime overzealous injection of the air, you can have pop sound or that big bubble burst. And usually it's associated with split of or retracted DM. Well, you can convert into PKP, or you can go deep, little deeper to get a proper idea of how the DM is there. If DM is not retracted, you can actually consider DALK, and you can use post-op gas tamponade. One such case where I'm using here dissector and a cannula. Now, as soon as I enter this thing and start injecting my bubble, yeah, there you go, pop sound. I understood immediately that pop is very much audible to the surgeon. I started manual dissection, and there you can see the DM is not retracted. The split can be seen, and I was encouraged to go ahead with DALK and put a gas post-operatively. Post-op, the graph remained clear and went on very well. And however, I realized when I was going through the case on ASOCT, I missed out this track, which was pre-existing. And I should not have done big bubble here. And that was my mistake to undergo that oops moment. Post-operatively, it went on well. I could see the split there on ASOCT as well as on slit lamp. The next part is opening of big bubble. Now, opening of big bubble can lead to perforation if the initial cut is that bold slash is very deep, or it's very slow. It can happen. It can be prevented by using cohesive OVD on surface, and where the gas bubble escapes little slowly. How do we salvage? If it is very large, you may have to convert to PKP, but if it's smaller, you can possibly put air and go ahead with DALK. The next part is stromal excision. Now, stromal excision, when you are doing, the sharp instrument can perforate if it's a big bubble, usually in the periphery. As you can see in the video, if it's manual DALK, usually in the center part where the perforation can occur. How do we manage it? Well, if you are able to put the flap back and put air inside, air stays inside, you can use fibrin glue also, or you can use small piece of stroma to secure that area and can still go ahead with DALK. The final part is the suturing part. Now, suturing part, usually the perforation occurs in the periphery, and especially while taking the recipient bite. Which can be missed, and you can end up with post-op double anterior chamber. Such kind of thing is not unusual. You may have to take up the patient again, put an air tamponade, and usually they resolve pretty easily. To summarize, these kind of oops moment of intra-perforation DALK is not uncommon. There are different steps of DALK can lead to different perforation and can be managed accordingly. Depending upon the location and size of perforation, you can decide whether you want to continue with the DALK or you want to convert to PKP. Thank you very much.